Hello, everyone. Thank you all for joining us today for Grunzenbach Lear & Associates webinar series presents Successful Grateful Patient Fundraising Programs, Practical Steps for Tapping the Fastest Growing Donor Segment in Healthcare, presented by Dan Lohman, Senior Vice President. Dan has served hundreds of client organizations since joining the firm in 2000, and an award-winning public speaker. Dan's areas of expertise include prospect management, research, analytics, and prospect identification. Dan has worked with more than 40 healthcare organizations to develop grateful patient fundraising programs, including major medical centers, specialty hospitals, and community healthcare providers. In today's session, Dan will discuss the potential of grateful patient fundraising programs for healthcare organizations and explain the key features of successful patient fundraising. Dan will also explore the challenges to effective programs and address issues related to data privacy, technology, and resource allocation. Lastly, he will present real-world case studies from academic medical centers and community hospitals. A question and answer session will take place after today's presentation. Please use the chat function on the right-hand side of your screen, select all participants from the drop-down menu, and send Dan your questions. Please feel free to keep your chat up throughout the presentation and share your thoughts and questions with your fellow attendees. Tomorrow, we will be sending a recording of the session along with the presentation slides and a short survey to gain your feedback. Thank you all again for joining us today, and now I'll turn it over to Dan to get us started.
Good afternoon. Thanks for taking some time to join us today for this webinar. I guess I should be careful saying good afternoon. We have people on the webinar from Hawaii to the United Kingdom, so thanks for whatever time of day it is for you. Webinars are always an interesting format to present this information because, of course, it's a one-way stream of information, although you are able to communicate with us through the chat function. So if you do have questions, don't hesitate to use that. And I want to try to figure out how to make my kids use that between the hours of 10 p.m. and 6 a.m. so that I can't actually hear them. I'd like to dive right in. My experience with healthcare is significant within GG&A and in terms of implementing these kinds of programs. I joined GG&A about 10 years ago, have worked with dozens of organizations, everything from elite major medical centers that have existing programs that are just looking to increase their yield in fairly established grateful patient programs, all the way down to small regional or local community hospitals that are just starting these kinds of programs. A lot of the challenges are frankly similar from one place to the other. Some places have more resources to throw at it. Other places it's a much bigger challenge. Some places have a terrific reputation for patient service that makes these kinds of programs a natural fit. Other kinds of environments, it's a different picture. And I want to try to address those differences, but really highlight the characteristics that are unique across successful programs, regardless of the type of organization or healthcare facility that they're specifically related to. Why do we need grateful patient programs is the good starting place. And one of the things we'll talk about are hospital CEOs and physicians who say we don't need one. And I want to challenge that and help arm you with some information to challenge that if it's appropriate. As you can see on the slide in front of you, this is from the AHP report on healthcare giving from 2008, which is the most recent year for which we have data. Healthcare institutions, and I should emphasize, these are standalone healthcare institutions. We can't always separate out the total dollar values with healthcare facilities affiliated with university settings. But in those standalone settings where there is data, 85% of the $8.5 billion raised from private support came from individuals. A much smaller proportion from corporations and foundations and that other category come from non-individual entities. So at the end of the day, it's all about people. And the second slide, also from 2008 data, shows the share of giving from different kinds of individuals. Individuals in the community, board members, employees. Patients represent 21% of that 2008 total, and something I don't have a slide for, but is terribly interesting. 10 years ago, and this is according to AAMC, Association of American Medical College data, almost 30% of total fundraising came from board members, private support came from board members, and only about 8% from patients. That switch really caught my eye when I noticed that data. Patients are the only segment where the percentage of total giving is getting bigger. This is a group of individuals that are representing the future in terms of where money is coming from in terms of healthcare private support, and for that reason, we need to at least evaluate the efficacy of that type of program. Even if an institution ultimately decides it's not their target, I think it warrants a high-level discussion about that kind of program. So why do we need grateful patient programs? Most healthcare giving comes from individuals. Patients, by definition, are neither corporations nor foundations, although sometimes it seems like they need resuscitation. Patients represent an increasingly large share of healthcare philanthropy, and perhaps most importantly, no one understands the services that you can offer to your community more than your patients. They've got the greatest stake in your success. They're the ones whose lives you saved, whose family members you've had tremendous impact on their health, their well-being, their interactions with life itself. And they're the ones who also live in the communities that you serve. So even in cases where we're not talking about actual patients who have had a major inpatient surgery, we may be talking about people who live in a community that appreciate having a healthcare facility like yours to deliver services when their child has a fever, all the way through the risk that they face in terms of all the healthcare issues that may face them in their lives. I'd go even a step farther and say business leadership in a community, it's important to be able to tell prospective employees that there's a healthcare facility in the community that can provide a certain level or top level of care. So patients, I think, become critical, not just in terms of their financial capability as a large population, but in terms of their interest in supporting your healthcare environment in a very specific and targeted way. As I mentioned, in my years of working with healthcare institutions, there are certain characteristics that we see across the board as being critical to the success of a grateful patient engagement program. And I should emphasize at this point, too, if you are, for example, a children's hospital, when I refer to patient programs, I'm, of course, referring to patient family or guarantor programs. So we're talking about people who have a medical relationship to the institution and their immediate family members, not specifically patients in every case. Some of those key characteristics, a distinct but integrated fundraising initiative, meaning there is a fundraising program, that there is an experience with philanthropy, that there's a cultural environment that supports philanthropy within your organization, but a specific component of that we've targeted to the patient population. Think about any other kind of fundraising entity. Take a higher education institution. The way that we speak to parents or speak to people in the community is different than the way that we speak to alumni. They don't have to be competing messages, but ultimately the things that will appeal to them are going to be somewhat different in terms of what's important to where their heart lies and where they want to put their private support and philanthropic dollars. We're going to talk about each of these items in a little more detail, by the way. Timely, analytically sound information. Some institutions have 500 beds, 1,000 beds, even if you only have 25 beds, if you multiply that by the number of inpatient visits, the number of outpatient visits, and the number of patients in physician practices, the numbers are huge. We can't possibly communicate with every single person in a face-to-face meeting about a major gift and wouldn't want to. So we need to make some decisions about how to target who we speak with and how we speak with them. Hospital experiences supporting continued contact, and we'll talk about this in some detail. How do we reach these individuals? What mechanisms exist to continue a relationship that goes beyond the moment of discharge? When someone's in a wheelchair getting into the taxi, it's not always the best time to talk to them about a gift. The full endorsement and support of leadership, critically important. If the CEO is not on board, a patient program will generally not be successful. And an engaged group of physicians, and I'm going to spend some time on that particular component in just a moment. On the topic of a distinct but integrated part of a fundraising program, in my experience, is programs that have dedicated staffing and a dedicated program budget will be more successful than those where these things are not clear. As we get into some of the implementation components that we'll speak about later on in the webinar, the amount of time that it takes to manage the information flow, make decisions, and then of course ultimately cultivate and solicit prospects is significant, extremely significant in some cases. If it's not clear who has responsibility for taking on those issues, the program will tend to fail. Gift officers, research directors, grateful patient program managers are generally very busy people with portfolios, with projects that they're supposed to work on, and it's rare to encounter someone who says, I've got an extra 20 hours a week and I'd like to fill it with an extra project like this. We need to find a way to create that space and have some accountability associated with it. Additionally, infrastructure and systems support, several items of which I've highlighted here, need to be set aside as well. Materials being one obvious example. Again, the way that we speak to a recently discharged patient about their experience and the importance of philanthropy is different than the way that we would speak to a high-capacity individual in the community who's interested in funding a research program that you may be affiliated with or managing. That means that we need dedicated time from the communications staff, the research staff, the prospect management team. All of those characteristics needs to be clearly defined as a specific component of the program with specific and documentable goals. There are a huge number of healthcare patients that move through the American healthcare system, and certainly those in other places for those of you who aren't in the United States. As I said, some environments that have multiple facilities, a large number of beds, and significant outpatient programs, it's not unusual for them to see 800,000 to 1 million individuals pass through their doors every year. Even a small environment, that number might be in the tens of thousands, but there's usually a concurrently small, correspondingly small staff associated with it from a fundraising standpoint. So there needs to be a mechanism in place as we look at a patient population, whether they're coming through the doors this instant or they will come through the doors or they have come through the doors over some past period of time, some process to determine how we want to communicate with different groups. Prior relationship is one mechanism that anyone can do at relatively no cost, looking at have they been donors, are they on the board, how many times have they used the facility in various different ways from a medical perspective. VIP lists, pulling in lists of people in your community or people from wealthy zip codes or using some externally supplied kinds of information that you can get from a variety of different sources that suggest that this person lives in a neighborhood that has high capacity or their household has some evidence of wealth, or if they're just on a list. Many local newspapers print the list of the 500 wealthiest individuals in the community. A number of hospitals pull that into their admission systems as a way to identify potentially interesting prospects. And then, of course, a more integrated and sophisticated wealth screening kind of process that an increasing number of healthcare facilities are engaging in, where lists of names are sent to be compared against outside sources that have information about business affiliations, philanthropy, charitable giving, political contributions, and so forth as another mechanism. The timing around this should depend on, first, how many names you're dealing with on a periodic basis, as well as how you plan to work with those names. There's been an increase in the last few years in daily patient screening, of having an ongoing process that's effectively real-time, saying these people are in the hospital and we want to talk to them, from these prior relationship VIP lists or external wealth screening kinds of sources. If you have the ability to act on that information, if you're going to actually engage in a relationship while a potential prospect is in your facility, daily is a perfectly reasonable mechanism to start to evaluate them. But if you're in a system where you're only going to evaluate this information once a month and send some post-discharge direct mail appeals, monthly might be a more appropriate mechanism. Notice, though, I have not put some other time frame on here. I was specifically limiting this to daily, weekly, or monthly. Quarterly is probably also okay, but regular is probably the key here. Doing this on an ad hoc basis is going to be significantly less successful if there's no expectation of when you're going to get resources from your mail house, from the communication staff, from the research staff. If we know that we're going to do this monthly or quarterly, time can be set aside within your program to make sure that the program is executed. A way to manage this easily and quickly, we'll talk a little bit more about some infrastructure issues. I have seen the gamut from Excel spreadsheets that have nothing to do with the patient system or donor management system all the way through highly integrated systems that include all of that information in one place. The trick is being able to get the right people from research, prospect management, major gifts, annual fund, and some other categories that we'll talk about in a minute, have access to the information they need quickly. I had a recent situation where the hospital was able to provide admission information to the foundation in a very timely way. Every morning at 6 a.m. that data arrived, but it took until 4 p.m. for another unit of the hospital to tell the foundation what floors and in what rooms their prospective prospects were in. By the time gift officers got to the nursing stations, most of the people had already been discharged. So managing it easily and quickly is an important component. It is a terrible idea to ask people for a gift while they are hooked up to an IV or when they've been sitting in the waiting room reading a 4-month-old Newsweek magazine. You want to get people at a moment where they feel like talking and they feel like having that kind of relationship. On the other side, well, that would suggest speed is everything. Waiting is everything. Speed, on the other hand, becomes important because our data suggests that after about 18 months, someone who has been a patient and has no other relationship with a healthcare facility becomes much, much less likely to become a significant prospect over time. This is the opposite of what we see in alumni populations where affinity tends to rise over time. So somewhere between those two things, we have to find a balance. And I'll tell you a somewhat redundant story. If you are effective fundraisers, you'll appreciate the comedy in this. I worked with an organization that screened a list of patients in their heart center. And we identified the chief financial officer, recently retired chief financial officer of a major corporation in their local community. And we'd rated from our data, rated the capacity of this individual at between $1 and $5 million. The director of development for the Heart Center called the person up, as was appropriate, invited them to take a tour of the Heart Center, learn more about the research that was going on. He accepted that invitation. The tour was going extremely well, but mind you, this was the first time that they'd ever met face-to-face. And 45 minutes into it, the director of development said, well, you seem like you're really interested. Could we interest you in a $1.5 million gift to name a faculty chair position? And the gentleman sort of wrung his hands for a moment and said, that's a lot for me right now, but I'll give you $500,000. I got an angry phone call 20 minutes later saying these ratings don't mean anything, that you rated this person between 1 and 5 million, and here he only said yes to 500,000. Of course, my reaction is this is terrific, that this is going in my marketing materials, and the fact is, what could you have done had you just waited until you'd had more engagement, introduced him to some of the physicians or the director of the Heart Center, and actually gone through the traditional cultivation and solicitation cycle, which is frankly not that different for any type of constituent. It comes back to relationships, and obviously that mechanism, just because somebody with capacity showed up in the hospital, did not make him a prospect. So the options for communication vary widely. Some institutions have implemented an in-hospital visit program, and even those vary widely. But this is a process of identifying people in the hospital today, whether they're current donors or have some indication of capacity or some combination of those things. And relevant staff, I'll get to who in just a minute, make visits, actually go up to the floor and introduce themselves in various ways and start to engage in a relationship at that point, usually in the context of, we're delighted that you've selected us for your healthcare. Is there anything we can do to make you more comfortable? Maybe leaving some additional materials or a card, obviously not getting into a heavy discussion about a gift at that point. More common than that are post-discharge mailings, which take a number of different forms, but say 4 weeks after discharge, people meeting certain criteria will receive a solicitation at a particular gift level, and that may be followed up with a telefund process. I've heard a couple of examples, successful examples recently, of face-to-face event programming. I had a great example from a hospital here in Chicago that ran a seminar for invited cardiology patients that they were able to identify to a seminar about what happened to Tim Russert, the NBC correspondent who suffered a massive heart attack a couple of years ago. And it worked through that medical case and what led to it and that sort of information. About 30 people turned up to it, and about 17 of them made gifts within 6 months of the event. Some were small, some were in the 5 figures, but all of them had never been donors before, and it created a mechanism where they could start to interact with the healthcare facility, not as patients, but almost as partners in an academic exercise, which clearly appealed to that particular group. There are 1,000 other webinars or conference sessions you can attend on social media and online interaction and those sorts of things, and I think it's worth exploring. Social media in particular as a way to engage hospital patients is something I haven't seen a lot of examples of, but strikes me as an area for some potential. When people walk out the door of a healthcare facility, at some level they want to be done with the place. It's not a place you want to come back to for most individuals under most circumstances. Are there opportunities taking advantage of your Facebook page, your blogs, your Twitter feeds, whatever the mechanism happens to be, and frankly that's even irrelevant, where you can start to connect, for example, patients in a particular disease state with experts in that field so people can talk about their experiences or what's going on in terms of new research. This can be hard to manage. You need content. Someone has to supply that data, and we'll talk about HIPAA in just a minute, but that would of course also require some sort of opt-in so that people can receive information related to a disease state in what may not necessarily be a confidential format. And then, of course, a combination of these things. I wouldn't just pick one. Successful programs have multiple avenues to reach individuals and pull in specific information and deliver to them specific information. Looking for opportunities within the medical interaction that go beyond the medical interaction. Obviously, we want to communicate genuine concern. My experience is that places that have a reputation for being mills and getting patients in and out as quickly as possible have a more difficult time raising money from those patient populations. We want to create personal connections. It's much easier to support a specific physician conducting clinical work or research, or a nursing staff, or a patient services person, or even a development officer who's developed a human relationship with an individual at a time that's usually difficult for them. If someone is undergoing an inpatient or even outpatient procedure in your facility, it's not a comfortable or happy event most of the time. Communications deliberately on there twice. How can we keep information flowing to these targeted prospect populations? And again, I'll emphasize this should be systematic, that this cannot be ad hoc. We cannot have one document that we leave with people when they're in the hospital and then hope that they follow up. Having a system in place that starts there but then moves into online communications, direct mail programs, telefund, events, any other sort of information. I just saw a question pop up on the chat that I want to address at this point. Someone asked about something like care pages, and it may be interesting to note at this point. In full disclosure, I said I worked at GGNA for 10 years. There was an 18-month gap where I did not work for GGNA, and I in fact was the vice president for business development at Care Pages. The Care Pages is basically a secure blog specific to a healthcare facility. So, you don't need a company like Care Pages to do it. You can build it yourself. There's other companies that do it. It's branded under the hospital environment, and what it allows patients and patient families to do is select individuals that they want to communicate with. So when the surgery goes well, instead of having to call 50 people and tell them that it went well, you can post to your Care Page. Everybody in that group gets a secure email, can check back in, see pictures, ask questions, and communicate through that mechanism, giving the patient and the family control over that communication, perhaps for the first time in their medical experience. Something like that is a terrific example. Again, I don't want to specifically push Care Pages, but that concept where it's secure, it's branded for the hospital, and what many hospitals who use those kinds of services do is capture the names and the email addresses of people who have joined those Care Pages. So now we've gone from having one prospect, the patient or the 2 or 3 immediate family members from a development standpoint. The average Care Page has 50 users. Some of them have thousands, some of them have a smaller number, but the average is 50. We've now got 50 people where we have a way to communicate with them, and someone they care about has had an experience that they're communicating about involving your organization's name. That can be a very effective mechanism if it's implemented well. Press Ganey scores correlate directly to philanthropy. Press Ganey, of course, being the patient satisfaction surveys. There are also other companies that provide that as well. We were just looking at some data at 15 academic medical centers, and it was a straight linear process where the higher the Press Ganey score, the average largest gift per donor and the average total fundraising. Places that had scores in the 50s and 60s on a 100-point scale had significantly lower philanthropy. And this ties into who's involved in a Grateful Patient program. This is not one research director and one major gift officer implementing this program. Patient services, the chairman of medicine, the nursing staff, all of these people fit into the picture because one bad experience can be enough to turn someone off permanently. I did not make these quotes up. I've been collecting them over the years. These are physicians and hospital leadership, non-development staff, and comments they've actually made about why raising money from patients directly isn't going to work for them. And you've probably heard some of these before, and what I want to get into is how to address these things. I don't want to use the word challenge because challenging a physician or challenging a hospital executive is usually not a terrific idea, but presenting them with information and support and guidance and data that can help them feel more comfortable with this process, and that ultimately does challenge these things. The fact is that HIPAA will let us do this as long as we are very careful and very thoughtful and beyond compliant. We need more than development staff to make the case for fundraising. We need to be able to say this money is going to go to support people like me who are doing this important work in cancer research. We don't treat anyone who has money to give. That's rarely the case. I'm sure there are some environments where that might be accurate, but I don't believe that it's true in most environments. And perhaps the most important one, I don't have time for this, which rather than saying, well, sure you do, we need to be able to come back and say, if we make the time, there's going to be a benefit that's tangible. What these physicians in particular usually mean, they're not used to this process. They're not in sales. They're not in development. It's not why they became hospital administrators or physicians for the most part. And it's difficult to learn how to do it comfortably in a way that supports the patient prospect more than anything else. And how do we get over some of these other issues? I don't want to be rejected. I don't want to be told no. I don't want to fail. How can we communicate that, first of all, some of those things will happen and it's not the end of the world, but also how do we prevent that? How do we create a process that they're comfortable with? particularly to healthcare leadership, the actions are guided by reliable data, that if you're in a position to say 40% of our patient population in a certain area have incomes in the top 10% of income earners nationally, or we're drawing from these zip codes that have the highest net worths in the U.S. News and World Report list that report those kinds of things, any of those kinds of things, or perhaps as importantly, institutional benchmarking. Call up 10 hospitals that are like you across the country, ask about their programs, and being able to say 8 of those 10 have grateful patient programs structured like this can often make that case. Supporting a big idea, big gift thinking. This isn't about $10 gifts. It can be as a pipeline to larger gifts, but making a case to leadership that these are million-dollar and multi-million-dollar opportunities in some cases, that if we're looking for $10 million to help staff a heart research facility and we need a source for that money, patients that have been affected by those kinds of programs and who have the capability to make those gifts directly translate into solving that financial problem. The other pieces here are really about the training component. Most of you on this call are directly related to the development operations in healthcare facilities, and you have the benefit of years of experience in terms of how to structure a fundraising program. And we need to think of physicians in some cases as we would think of deans, academic leadership, or a brand new fundraiser. What's the process? How do we do these things? How do we keep the information secure and confidential and start to generate a very personal relationship with individuals that they want to support? Making a case to physicians, I think these are in many cases self-evident. It's relevant to their needs. Physicians want to raise money for things that are important to them, and as much as this will actually conflict with what we might tell hospital leadership, where we can raise lots of unrestricted money, physicians at some level will generally need to hear that a significant portion of these funds will go to support programs that are important to them. Recognizing and acknowledging successes. I hate to generalize, but I'm a demographer, and that's what we do. Physicians like to win. That's why they went to medical school. That's why they have done the things that they've done. If they're particularly prominent physicians in your environment, they like to be recognized. They like to be known for being successful at everything they do. Being the best heart surgeon is part of that. Being a top fundraiser for a healthcare facility can be part of that too, and we need to do that in a way that's appropriate to them. You know, we've all watched, well, if you're of a certain generation, you watched Emergency on TV in the 70s. It was a show that changed my life, quite frankly. The stat we all heard a million times, physicians want things fast. How can we deliver results? It's not enough to have a number of roundtable discussions about how to implement a grateful patient program. Being able to go to a physician group and say, we want to do these things and we want to start next week, will have more impact than a long-term development process around it. The CEO needs to be on board. It is effectively impossible to get the buy-in from any of the other important constituencies here without the CEO being fully on board. That ranges from a CEO directive that physicians and chairmen and directors of nursing need to play a role in the fundraising engagement process, all the way down to his willingness to have his or her name signed on the letter that goes out. I recently encountered a healthcare executive who was unwilling to visit constituents, even if they were significant past donors in the hospital room, because he didn't know what to say. And it ultimately became a training exercise of here are some things to say. And it comes down to, I just wanted to say thank you. I wanted to say hello. If you need anything, call my office directly. Never talking about money, never talking about the next gift, never referencing the past gifts directly, but giving that executive the tools that he felt he needed to be comfortable in that environment, and it's worked. I'm a huge proponent of actually more of the formal physician advocacy and champion groups, although I recognize that informal may be necessary in certain environments. If you can identify a small number, maybe it's only 3 physicians that are willing to work with you at considering a parallel group or a joint group with nurses, that will be on board with this, that will go through a training program, that will visit constituents with you in person, that will understand the way you collect data and use that information. Even if we only start with 3, we find ourselves in a place that we can now take it to other physicians who are much more likely to listen to their peers than they are to any of us on the development side, the vast majority of the time. Once they start to have successes, we can start to extend those successes across a wider range of departments, facilities, staff members. Some basis for projecting outcomes is important as you start to put a program in place or try to grow a program. Some examples of this would certainly be institutional benchmarking, that process of contacting peer organizations or aspirant peer organizations and getting a sense of their programs. If you call hospitals that are not in your local area, generally speaking, they're not competing with you for patients or philanthropic dollars. There are some exceptions to that, of course, but consider that every city probably has a hospital much like yours in one form or another. Speaking to them, very frequently, I'm always amazed at the collegiality of development offices around the country and around the world. Because it's non-competitive, your peers are a great resource for this kind of information. Data that you may be able to get from your marketing department already or can certainly acquire from outside sources about the demographics of the patient population. Being able to describe that there are X number of people with this set of demographics, say age and income or from these zip codes, that come through our doors every year becomes a mechanism to say, even if we're right only one time out of 100, that translates to X individuals that we can talk to about gifts. Screening another opportunity to provide that kind of information. This is too general to even be useful. The flexibility as you work with physician groups, with other people on staff, nurses, this is new to them too in many cases, and working with them to become more comfortable is extremely important. An orientation and training program is critically important. We have to find a way to communicate to hospital leadership and the physician staff, these are the things that we want to do, this is how we want to do it. Make it easy for them. Create a guide, create a systematic approach that they can follow with partnership from the development office to move these things forward. With some regularity, I speak with organizations that say we're going to start a Grateful Patient program and we want to well screen our patients, we're ready to get started. And with much less regularity and frequency do I encounter organizations that have necessarily thought through all of the downstream effects of that. And I'm mostly presenting this in the form of questions that need to be answered because there are different answers in every environment. Certainly budget and staffing, I emphasized at the outset the need for specific budget and staffing resources be dedicated to a Grateful Patient program. That does not mean that there has to be a full-time Grateful Patient engagement coordinator or director, but it does mean that someone has to have a portion of their time carved out for this specific initiative. Who's going to meet with prospects? If you have 5 gift officers and they all have portfolios of 150 individuals and they all claim to be busy, that doesn't create an opportunity to add new prospects into that pipeline in any way that's going to be treated with priority. So defining that is important. Who will collect patient information? And we'll talk about compliance in just a minute, but data has to get to the development office from the hospital somehow about who has been patients, and creating staff resources to do that, and managing the information flow. A sample information flow might be a constituent is admitted to the hospital for a procedure. That list is sent to the development office. The development office sends that list to an external vendor for wealth screening. Top-rated prospects are returned. That list has to be compared against the donor database and the risk management database. And then room numbers have to be acquired, nursing stations have to be checked with, and gift officers have to be deployed to the floor, and then a contact report has to be entered. It's not a straight line, and I probably left out about 17 other steps that might have to occur. Someone has to be on top of that. A plan has to be in place, it has to be documentable, and it has to still work when that staff person is out for the day. Defining who is a patient prospect, inpatients are generally the focus of Grateful Patient programs, although I think outpatients represent a terrific opportunity. And keep in mind what outpatient means today. The average length of stay in a hospital has declined from 5 days 6 years ago to just over 3 days in 2010. People are moving out of hospitals much more quickly. The concept of inpatient is becoming much more blurred. Cancer treatment, for the most part, for most people, is now an outpatient procedure for many, many cancer patients. Considering those kinds of things is important. Who do you want to look at and who might be a good prospect? And then other kinds of details. Are there exclusions that you want to look at or inclusions that you want to look at? Do we want to exclude anybody under 35? Do we want to exclude psychiatric, AIDS patients, abortion, any of those kinds of services? There's no HIPAA reason to exclude those. There's not a compliance or legal reason for the most part. Sometimes there's an extra layer of security and privacy required. So it really becomes a question of what you feel is appropriate and what your hospital leadership feels is appropriate. And I always like to apply what people call the headline test. How would this look if it made the front page of your local paper? It is entirely defensible to say that we have, like many organizations, evaluate people who may be interested in philanthropy. It may have a different appearance if there's specific disease states or other kinds of issues, certainly if they conflict with HIPAA requirements. The data and technology issues, things as mundane as where do you get the patient list and the room numbers and those sorts of things. Where do you store this information? Patient admission systems and accommodation systems are not set up to support philanthropy. At least I'm not aware of one that does that with any degree of utility. Donor management systems are not always set up with the privacy requirements that are necessary to maintain lists of patient information, even if it's just the permissible name and address and date of service kinds of data that development offices can get under HIPAA. So I've seen, again, a whole range of things, totally, completely separate side systems and so forth. Other kinds of mechanisms to address that, but it just needs to be answered. Compliance with HIPAA, critical. If you send data to an outside source, insist on a business associates agreement. Make sure that your HIPAA compliance office has approved this. I do not encourage you to just go ahead and do it and ask for forgiveness later. This is one of those cases where permission is something you definitely want to have. HIPAA's serious business, and you want to get this right. Talking to risk management staff within the facility, risk management meaning people who are unlikely to be able to pay their bills, people who have lawsuits filed against the organization, other kinds of groups that may not, where it may not be beneficial to include them. Opt-ins and opt-outs, about 50% of the institutions with which I have relationships are on the opt-in side and 50% on the opt-out side. So the opt-ins, of course, you've got to sign something that says it is okay for development to contact me. Opt-out saying I refuse to let you do that, or however that's phrased. So that split in terms of the request, I think, is indicative of that there is no defined best practice at this stage, and I think ultimately we have to rely on our judgment about what will be successful and what will pass muster with compliance offices on the healthcare delivery side of the organization. And certainly data security, that if you in an independent foundation or a development office are handling patient information, you absolutely need to be able to say that your data security and privacy policies are stronger or as strong as electronic medical record systems. It just eliminates the whole debate and concern about HIPAA violation risk on the development side, which is something we absolutely want to avoid. Some implementation steps. I will apologize in advance to a person who's on the call who will recognize this because I lifted it from his presentation. This is one medical center's journey. I had crammed what's now 2 slides into 1 slide, and my marketing partners insisted on splitting it into 2 slides. I wanted it on 1 slide because it just showed how much stuff they had to do and how long it took them. So starting back in 2006, this organization first started to acquire inpatient lists for their own internal consumption from the hospital. Several months later, they started to put systems in place to think about mailing lists, developing opt-out processes for those solicitation mailings, getting initial approval from HIPAA and the General Counsel. And then look what happens, that we jump to spring 2008 where discussions begin to create a comprehensive patient list. A few months later, HIPAA and senior management were briefed again. And something many of you will recognize, hospital IT staff delayed the project for almost 6 months because they had another priority. Not that EMRs are not an important priority, but again, you probably recognize this in many of your environments. And only in the last several months, really, did a comprehensive patient list come into being that could be solicited, that had appropriate opt-outs where decisions were made about HIPAA compliance, about department interactions, all of those other components. And currently, the organization is going through a compliance audit to ensure that they're on track. But it was a 4-year span from the incarnation of the idea to what we might call a final version. This is a very general flow chart from one institution about how their process works, and in fact, that was also a 2-page flow chart, and I'm only showing 1 in this presentation. And you can see how the process works as data moves around through different components into different systems. This is an institution that does not do in-hospital visits. They mail after discharge, follow up with major gift officers, and then continue into an annual giving process, which is separate and apart, but only begins for people that haven't been determined to be major gift prospects. Another organization that we've worked with identified rating levels. So through a combination of external data and verification by a dedicated research person who started the day at 8 a.m. with the patient list with a goal of by 9:30 identifying constituents at these levels who would then require an in-hospital follow-up. And you can see how this organization has structured it. A rotating cycle of hospital executives, the senior vice presidents, the president, chairman of medicine, the CEO, who on a cyclical basis would be asked to go visit constituents rated with capability of $500,000 or more. I want to emphasize that even in the most elite organizations, the number of $500,000 constituents that come through the doors on any given day is small. At this hospital, it happened once or twice a week, so the odds that a senior executive had to go visit somebody on their day was, hit or miss. So it wound up being about an hour every 2 weeks out of these individuals' staff time. By going through all of the other processes that we described earlier, they were in a position to make them comfortable with that process and move forward. And then the other categories, the foundation executive of the day, the president of the foundation or a senior vice president, and then gift officers of the day, major gift officers who just carved out time from 10 to 11:30 in the morning to effectively round, go visit the 6 people in different units. And then you can see the other opportunities there. Quickly on some outcomes. One organization's experience with 6 months worth of an annual fund program. They used a combination of internal and external information to solicit 11,919 patients from that 6-month time period based on wealth data and other relationship information. They had 120 gifts, a 1% response rate, total raised from this pool, just over $25,000 with an average gift of $212. They shifted tactics a few months in and started to only solicit a smaller population of higher capability individuals and went out with a higher ask and a higher quality mailing. The ask was $1,000, the average gift was $1,200. And you can see their ROI. They spent about $18,000 on the project. They raised $25,000. Is this going to make the institution rich? Not yet, but we've created a pool of 120 individuals that have started to contribute to the annual fund. They've started to develop a philanthropic relationship born from their patient experience. It's too early to tell what the long-term outcome will be. And in this case, they've recently received a $10,000 memorial gift from a family that had responded to one of these gifts earlier, and that's not included in the $25,000 total. Some other results from another type of organization from the first 3 quarters of fiscal year 2010. The areas were specific disease state centers within the organization versus unrestricted. And here you can see clearly a major gifts and plan giving focus on this part of the program, and some significant numbers raised, although again, no $10 million gift on there, that the numbers show up in various different places. So we're seeing some successes, although again, it's not the basis for a multi-million-dollar campaign. Patients represent an enormous growth opportunity. They're growing, they care about you, they interact with you, you have an opportunity to interact with them directly. But implementing this kind of program isn't simple, just like any part of fundraising isn't simple. It doesn't matter how good your database is or how many gifts you process every year. The only thing that matters is how do we develop relationships with individuals that will ultimately make larger gifts. Formal programs for grateful patients are relatively new. There are very few places that can say, hand on heart, they've been doing it in an organized fashion for more than 3 or 4 years. And I don't think we know yet what the long-term viability of a major gifts program is. I have many, many anecdotes that it works, and that leads to the next point. The logic here is sound, and the risk of not building a program like this means relying on general acquisition efforts and hoping that your board and your development staff can make connections with people who want to support. And I'll actually leave you with a directive. Track your results as you implement these things. Start to look carefully at how a constituent came into the system. Were they patients? What did you do? When did they give? Because ultimately we can all learn from the best practices and raise healthcare philanthropy within that. Questions?
Yes, we have about 10 minutes remaining in the hour, so we ask anyone with questions to please respond using the chat function in the right-hand side of your screen. We'll try to get through as many of your questions today as possible. Anything that we do not get to in today's time, we'll have Dan respond to you in the coming week. We do have a few questions that were submitted in advance of today's session. We'll go ahead and get started with those and leave you all a minute to submit your questions.
One is, what children's hospitals conduct grateful patient programs and how do they handle it? In this public setting, I'm going to leave names of organizations out of this, but there is an increasing number of children's hospitals that are integrating programs. In principle, based on the generalities I've talked about today, there's not a huge difference with the obvious exception that parents and grandparents are the prospects rather than the actual patients. One obvious feature of grateful guarantor programs, if you will, in children's hospital settings is that the parents of children in children's hospitals, almost by definition, are relatively young. They tend to be between 25 and 45, maybe slightly older, but on average they're certainly in that range, where in a general care facility the average is into the 60s. That limits the philanthropic capability of that population, but this comes back to things like grandparents, aunts, uncles, other people who may have strong relationships, that smaller number of parents who do have significant capability. Something like a care pages-like system that creates communities around patient families can be an effective mechanism for that. There was a question, when and how did organizations provide patients with opt-in and with opt-out opportunities? Another excellent question. Many do it at the time of admission. It's the easiest way to get it into their system. I will comment on whether or not I think it's the best for fundraising in just a moment, but it's because there's a lot of papers being signed, it's easy to get it to put into the packet. The downside, of course, is that not everybody's reading those materials at that point, and you may run into issues down the road where people may have signed something they didn't expect to sign. So I think that we're seeing an increase in opt-in, opt-out opportunities once discussions about fundraising actually begin. So it's included on mailings that go out, certainly. And if you get to a point where there's a more detailed discussion that comes up, and it's the role of the gift officer to present it. There's a question, in the approach to cardiology patients, how is the institution able to segment? It's a good question. Some places can't. The HIPAA regulations don't permit individuals don't permit development staffs to specifically see disease state information. In the case that I was referring to, it was a separate center that was a heart center affiliated with a large organization. And in those cases, you can check with your HIPAA compliance people before you act on this, but generally speaking, the interpretation has been if you are a standalone system or have a standalone facility that can be clearly and easily identified, like you are a cancer hospital only, that kind of information is permissible. In other kinds of environments, other kinds of questions are asked where you start to pull in information about what people's interest areas are, not necessarily on their disease state. Another question, how do most institutions find out people are deceased before they are contacted? There are a number of companies, they're big ones like Experian and Axiom, the major data providers, as well as smaller companies that only serve nonprofit fundraising, that can provide what's called a deceased append or a comparison against the Social Security Death Index. It isn't 100%, but it's close, and in those cases, the list can be checked against those sources to determine that information.
Another question we have what do you do if the community culture isn't supportive of grateful patient fundraising? For instance, media articles that are condemning the process.
That's an excellent question. The challenge at that point is communicating that you are going to do it in a very sincere, very thoughtful way that does not put patient information at risk, that is very sensitive to the needs of the patient population first and foremost. I think benchmarking comes back to this, that if you're in a position to be able to say other hospitals that we compare ourselves to are doing this and they're doing it with these protections put in place, we can start to make a case. And then the third piece is one of opportunity, that you do have to ask the question, if you are expecting the development office to raise X amount of money in a certain time frame and you are excluding an obvious potential source of funding from this population, where is that money going to come from? If none of those things work, I think there are opportunities to do much more generalized approaches. You may be able to coordinate with the hospital in a way that development never actually sees a patient list, that the direct mail or annual giving program, at least a piece of it, is run directly from the hospital marketing department with no patient information, no clear indicator that this person has been a patient. And then only when they respond to those appeals do they actually become prospects.
We have one institution, of course, concerned with being HIPAA compliant, and along your mention of using care pages and access to additional emails for family members and follow-up, how do you obtain permission from each person that the family allows to access the care page?
Good question. So as long as you're not accessing the care page, there actually isn't a HIPAA issue with you having the names and the email addresses of other people that are affiliated with the care page. So on the one hand, there may not be a HIPAA issue at all. That said, when I was at Care Pages, and actually some joint clients, it's actually how I wound up at Care Pages, and why I came back was that we were working with a lot of the same places trying to use Care Pages for fundraising purposes. A major medical center center in the Midwest that was using care pages after the third visit to the same care page. So they didn't do it the first or second time, but effectively a pop-up appeared that said the University of X is interested in communicating with you. Would you be willing to hear from the foundation, or however they phrased it, something to that effect. And they built it right into the system. So somebody had to check a box and say, I accept, giving the foundation, in that case, permission to communicate this information.
Okay, great. I think we have time for one more question.
The question is how families of patients who have passed away in the hospital remain HIPAA compliant. That's actually an excellent question. I don't know the answer. I will have to find out. I'm not sure what happens to the privacy of HIPAA information after someone's passed away. In some cases, a lot of that information, a lot of those regulations, the compliance issues cease to exist. So we know who that question is from. I will dig into that and see if I can get you a response.
Okay, great. Thank you so much, Dan, and thank you everyone for joining us today. Again, we will be sending a follow-up email tomorrow that will include today's session recording along with the presentation slides and a short survey. We have Dan's email address up on the screen, so feel free to send him any additional questions that you have following today's session. Thank you all.